Hello dear friends, how are you doing today? I hope you are doing well. Let's evaluate another question of dermatology. A 47-year-old lorry driver presents with the development of a widespread urticarial rash. This is associated with pruritus. What is the most appropriate medication to help relieve the itch? A. Cetirizine, B. Loratadine, C. Chlorpheniramine, D. Ranitidine, and E. Elimimazine. Okay, here we have a 47-year-old lorry driver coming with the development of a widespread urticarial rash, and the patient also has pruritus. The question is asking about the most appropriate medication to help relieve the itch. And the most appropriate medication amongst the choices is loratadine, especially in lorry drivers. Loratadine is the most appropriate medication. Here we are going to explain it. Explanation: the obvious concerns for a lorry driver is drowsiness. Of the non-sedating antihistamines, there is some evidence that cetirizine causes more drowsiness than loratadine. Urticaria. Urticaria is a common skin reaction characterized by the sudden appearance of transient itchy raised welts or hives on the skin due to the release of histamine and other mediators from mast cells. Lesions are usually superficial dermal swellings. Each will typically last less than 24 hours, but new ones can appear in crops. If the swelling involves deeper dermis or subcutaneous tissue, then angioedema can be the result. Clinical features: welts or hives arise erythematous or skin colored with a central pallor. Size: a few millimeters to several centimeters may coalesce into large plaques. Pruritus or itching: very intense pruritus or itching can be present and is a hallmark symptom. Transient: individual lesions resolve within 24 hours, but the oral rash may last days to weeks. Distribution: any part of the body can be involved, often trunk, limbs, and face. May be accompanied by angioedema or swelling of lips, eyelids, tongue, hands, feet, and genitalia. Okay, here we can see the urticaria or the hives on the back of this patient. They are really itchy. And here also we can see the lesions of urticaria on the back of these patients. Classification: acute urticaria, less than 6 weeks, often allergic, infectious causes. Chronic urticaria lasts more than 6 weeks and recurrent, often idiopathic, autoimmune, or physical triggers are responsible. And physical urticaria, triggered by physical stimuli like dermatographism or scratching the skin, cold, heat, pressure, cholinergic, sweating, exercise, and solar are physical triggers for urticaria. Causes and triggers: allergic, immunoglobulin E mediated, like foods like nuts, seafood, eggs, milk, drugs like penicillin, NSAIDs, and aspirin. Insect stings and bites are allergic causes of urticaria or will. Infectious causes: infections like viral infections, especially in children, bacterial and parasitic infections. Non-allergic triggers like cold, heat, pressure, stress, exercise. Systemic disease like autoimmune thyroid disease, systemic lupus erythematosus, mastocytosis, and idiopathic in many chronic cases also are the causes. Pathophysiology: a trigger leads to mast cell degranulation, which leads to release of histamine, leukotrienes, and prostaglandins, which leads to vasodilation and erythema. Increased vascular permeability, which leads to edema and welts and angioedema, and nerve stimulation, which leads to itching. Diagnosis of urticaria: the diagnosis is mostly clinical, but look for possible triggers like drug history, infections, systemic symptoms, and in chronic urticaria may require a basic workup like CBCS or CRP. thyroid function test, and autoimmune screening. Treatment of urticaria. General measures: avoid known triggers like foods, drugs, physical stimuli, loose clothing, and avoid alcohol and size, which can worsen the urticaria. Medications. First line medications are non-sedating H1 antihistamines like cetirizine, loratadine, and fexofenadine. If inadequate, increase dose up to 4 times standard. A second line, add H2 blockers like famotidine or leukotriene antagonist like montelukast. In severe cases, short course of corticosteroids, example prednisolone, is indicated. In refractory and chronic urticaria, omalizumab, which is an anti-immunoglobulin E monoclonal antibody, or cyclosporine are useful. In angioedema or anaphylaxis risk, if systemic involvement like difficulty breathing and hypotension is present, treat as anaphylaxis with epinephrine, and AOA management is necessary and important. Prognosis of urticaria. Acute urticaria usually is self-limited, days to weeks, and chronic urticaria may persist for months to years, but often resolves eventually. Okay, this was a short explanation about urticaria, the causes, and the management. Thank you for your attention.